can share. Yeah, while you're being public servants, yeah, anybody want to go into politics? Let's face it, lots of fun. I did first want to ask if there were any questions about last time. I I expect a lot of you haven't spent a lot of time on it since then. And when you'll really have questions is um, when you start doing PPOR. And by the way, your questions are welcome then too. I get emails all the time from people who are doing PPOR and just have a random issue or thing they want to ask about. So I also, I mean, I can, review results and say, what does this mean? Has anybody else found a result like this? That kind of thing. Get those all the time. Happy to do those. They don't take a lot of time for me. And can everybody hear me okay? And Ash, let you be the judge.
Yes.
Okay.
And I'm helping monitor chat too. So I have
Okay.
my eyeballs on that.
So nobody wants me to go start with phase one or the exercise or anything like that at this point. I will go right ahead with this phase two stuff. So one of the things we learned last time is that you have to do phase two. A lot of people skip that part. Really, people feel so relieved that they got phase one done. And sometimes the community just runs away. Oh, we know the answer, but we don't. We have to check with the data on those answers too, those more in-depth answers. So in phase one analysis, all we did was identify the important gap, a risk period that accounts for a big proportion of the community's preventable deaths, and a population. So we can focus on a risk period and a population. Sometimes it's 2 risk periods, sometimes it's even 3. But we found gaps. But in phase 2, we have to figure out the why. You can't just go ahead and assume that your gap is caused by the same reason as someone else's gap, because there are differences. Similarities too across the country, but there are differences, so you have to check. So that's what phase 2 is for. So yeah, phase 1 tells us which risk periods, which populations, as we tackle the reference group question in phase 1. We use that same reference group in phase 2. So it's important to get that right. And sometimes we need to use more than one reference group to satisfy our constituencies. And it's okay to use more than one reference group. I didn't talk about that last time, but more than one reference group for your own analysis, for maybe your small group of data geeks analysis is helpful. Putting out a lot of this data to the community can be just confusing. So phase 1 and phase 2. So phase 2 analysis has 3 major steps. The first part is to identify the causal pathways or mechanisms. And that seems like the obvious thing. Why did this happen? But it's not always so easy to tell. The second step is to look at the risk factors for those causes. That is the known risk factors. And then you compare the study and the reference group with those risk factors. In the step 1, you also use the reference group. In the third step, you estimate the potential impact of the risk factors that you find to be important on excess mortality. And in step 3, you're looking within the study population. And I'll show you more about what that means as we go along. So there is an overall strategy for phase 2. It's really a lot of it is to figure out which factors are not likely to be contributing in your community. There's a ton of factors that are important in infant mortality in general, but some of them are more likely to be contributing in your community, and some are more likely to be contributing to excess mortality, preventable mortality. Remember, that's what's different about PPOR, because you got that reference group, you're estimating preventable mortality. And then the second part is, of course, to find a few factors that are probably likely to be contributing. And another part of the strategy is you bring in all kinds of information, not just vital records data. It's important to use what you've got in vital records data, but pull in other sources too, and find ways to make the community voice come to the table. They are a source. They They have things to tell us, especially about interpreting findings and remembering this sort of a golden rule that I have nothing about us without us. I think many people are using that rule better in now than used to be done. Used to be sort of a, I'm from the government, I know what's good for you, and it just doesn't work. So phase two, the three steps. The first one, identifying the causal pathways or mechanisms. Second one, identifying the risk factors, and third, the impact. So we're going to start with the green box because that's the simplest. And if you remember from phase one, that's called the infant health period, and it's babies that were born at greater than 1,500 grams and survived their first month. So they've lived 28 days, but they died before their first birthday. So a lot of these are sleep-related infant deaths, and the other cause groups that tend to come in this category are accidental injuries. These are usually babies who have gone home from the hospital. They've lived at least a month. Very few end up being on purpose injuries, assaults, or homicides. There sometimes infections come up, sometimes congenital anomalies come up as a preventable thing in this period, but not very much. Mostly in many places, everything is very small. All of these categories are small except for sleep-related infant death. But you have to check because it's not always that way. So first we're going to calculate group the causes of death codes in a way that makes sense for us. Then we're going to calculate cause-specific mortality rates for those cause groups. And then we're going to compare the study population and the reference population for the same cause groups. This is sort of a schematic of how it goes. In phase one, we found that the infant health gap is important. In phase two, the first step is to figure out which causes are important. And here's in this case that I've put in the schematic, SUID is the important one. So we look at risk factors for SUID for our next part of our phase two. We look at those risk factors, prevalence of the risk factors, comparing the study population to the reference population. So it is important. Okay, so for the infant death period, the ways to group the causes of death, you can do it multiple ways, but one of the important things to do is to use 3 different codes for SUID. Some places use more codes than this. This has been in the literature for quite a while now. Carrie Shapiro-Mendoza did quite a bit of research. It's also easy for you to do it at using your state child death review. You can look at how the causes on ooh, somebody's needs to be muted, I
I
think.
got it.
How the causes of death uh, on the vital records compared with the causes of death that they found in the child death review. That can tell you that there's overlap between these causes. A lot of times, if you do that across tabulation between those two, you'll see that SIDS is misclassified as ill-defined, or the other way around, and suffocation and strangulation in bed is often classified as SIDS when it shouldn't be. And since all of these things have the same prevention action, it's recommended to group them in causes. And maybe you already know that, but if you're not deep into MCH yet, you might not. So it's important to do that. Anybody have questions about that? Is that new and different? Believable? Is anybody awake out there?
Dr. Gilbert, I have a question.
Go for it.
When you say misclassified, you mean like after like the mortality review reviews that case, they're like, oh, the death certificate said SIDS, but actually it was this according to this committee. That's what you mean, right?
Yes, exactly.
Thank you.
Yeah. Vital records
Yeah,
has some less detail to work with than the
totally.
mortality review
Thanks.
committee. Yeah, exactly. So, gone to the next step examining the risk factors. So if we found out that SIDS was important and we found some important risk factors that have differences in prevalence, we can look at the risk factors using CDC Wonder. CDC Wonder, actually, you can use that for your causes of death as well. If your population is big enough, CDC Wonder will suppress data that's small numbers, so you can't do it if you're a small population. But you can do the risk factors, many of the risk factors from vital records. Some of them are, it's important to notice that some are proxies, and some are real causes, but mostly they're proxies. And we like to look at the risk factors that are related to social systems because those are the things that don't get looked at elsewhere, and they are powerful. Social factors often come up. You'll see examples of that. Wanted to have a note here about race as a social factor. A person's race can be an important marker for all kinds of benefits that are available to a person based on race in the United States, not only in the time of their pregnancy, but over their lifetime and across generations. Race is important. So some suggestions about using race. Think of these populations as priority populations rather than treating race as a risk factor. And that is a concrete step to do. Focus on the population. Don't just put it in a model or study it as a risk factor. If numbers are too small to analyze the population separately, use other data, use death reviews, take specific steps to make sure that the interventions benefit the vulnerable groups. So you may not be able to study the group in great detail, but you can focus on making sure that the interventions you do choose will benefit that priority population. You can also add mixed race people to a race group that's a priority population. This is really important to the smaller populations because a large proportion of them are multiple race, people who check multiple boxes on the race thing. Native Americans is more than half in a lot of places. More than half are mixed race. And so if you take out the multiple race people and put them into the other category, as we often do, you're going to miss half the Native Americans in your population. And so take a look, this varies. And I mentioned that in the other presentation, so I won't beat it into the ground here. So this is an example of that first step part of the risk factor analysis, just prevalence, just something you learned in your very first epi class. Look at the prevalences, but also compare them to the reference group. The prevalence, and this is something that's pretty well known, that the population of deaths is way different in terms of risk factors compared to the population of births, or the reference group is much better. So much lower prevalence of risk factors in the reference group population. But then the risk ratio, you get that from those two numbers, and you can so point to things that have higher risk ratios. Here are in red. And of course, some of these are known causes. Tobacco use is a cause of SIDS. The last step is the potential impact part. And we like to ask both of the questions: how prevalent is the risk factor? And then what is the severity of the risk factor? For severity, we use the relative risk or the odds ratio. But from that information, you can estimate some importance. So SUID risk ratio, and this I used CDC Wonder to get this, and I used I used the metropolitan counties in the Midwest census region. So I'd have a big number so I could get lots of risk factors in here. And you can see that risk ratios are high, vary a lot here. Mother born outside of the United States is actually protective, 0.3 risk ratio. And I wanted to mention population attributable risk as a good tool for this. In PPOR, what you're trying to do is prioritize among the risk factors, prioritize among the possible ways you could take action. And PAR is just a good little tool to give you a numerical answer about that. How important is it? It takes into account both the prevalence and the risk ratio, the strength of the severity of the thing. And it answers this question. If all the people had the same low risk as the people who don't have the risk factor, then how much would the outcome prevalence decrease? Really simple question, and you can do this. So for example, if we could make everyone have the same low birth weight risk as our non-smokers have, how much would our overall low birth weight rate decrease? So here's an example. This is the formulas for population attributable risk, and there's two formulas that are exactly equivalent. They look different. This on the bottom here, the two equivalent formulas. The most direct one is the P0 minus P2, but this one with that's converted into RR is handy because you can use adjusted RRs, risk ratios, for that one, and you can find adjusted ones sometimes in the literature, or you can make your own adjusted ones. So here's a table with real data in it. So the question again, if we could make everyone have the same risk of low birth weight as our non-smokers have, and that is 0.074, our non-smoker row. 0.074. If everyone could have that risk, that would be taking the everyone part is the 248,000 number. That's everyone. Multiplying by that low risk gives you how many low birth weight births you would have. Then you need to compare it to the low birth weight births you actually had to get the percent that you saved. This is sort of just the logical way of thinking about PAR. So you subtract and divide by the original value, and you get a 0.0166 PAR. So the percent of low birth weight births that you would save is just 1.66%, a very small percent. So this is helpful information if you're a health department trying to prioritize. This might be something that is something known, that's a known cause, but in this community, it looks like it's not going to be very important compared to other ones. So
Dr.
this,
Dr. Gilbert, do you mind to repeat the steps where you compare the hypothetical to the real one, please? I got a little lost there.
Okay, gotcha. So if you go back to the way we figured out how many real births we had was taking that 0.074 times the actual population. And you can just use the formula too, but it's fun to do it this way because then you know what you're doing and why you're doing it. So what percentage did we save? The actual is 18,648. The theoretical came from that slide before. How much if everyone had the low rate of the non-smokers, 18,338. The difference divided by the actual value is the PAR. So this tells you what percent of low birth weight births could we save. Does that make sense?
Yes, it does. Thank you.
Alrighty, you're welcome. So this does the same process for all those risk factors. And you can see if you were sort of looking at risk ratios and prevalences, you'd have a lot of choices to make. Which factors are important? How do you make some rise to the top and others not? And the PAR is a good tool for that. It's not infallible at all. I'm going to go over some of the problems with it after this, but you can rank your factors according to this combination of prevalence and risk ratio. So look what comes to the top: unmarried, Medicaid, and high school or less education. All three of those are social factors. I'm just saying. So, and then there's a bunch that are kind of in the middle in this case. One of them is a social factor, being unmarried, and with no paternity acknowledgement. So it's a little bit different from unmarried. Late prenatal care. not breastfed, tobacco use and young age are all sort of in between. But if we wanted to really focus on the things that could have the biggest impact, we might want to start with the top three there. And we don't have to. And this is sort of the downside, the caveats. It doesn't adjust for other risk factors. You can do adjusting in and use the RR formula that with an adjusted risk ratio. You can adjust with regression. That's pretty easy to do. But you might not want to because our vital records data has a lot of quality issues, and we can sometimes get really odd answers because of the missing data and low, data things that are known to be underreported in vital records. So it's better to get adjusted data from a study where things are carefully controlled, maybe where they used medical records reviews or something like that, provided that it's a population that's similar to yours. There's a lot of mushy stuff in here and judgment that's needed. And it's better if the epi isn't sitting in their own office just talking to themselves when these decisions have to be made. This is a great opportunity when there are decisions like this to involve the community, involve people from other sectors. If they have the patience to listen to you, say, if I adjust this myself, I get this number. If it's adjusted by the ratio from a study, I get that number. Do we think that smoking is important? And for that, you might want to look at confidence intervals because the PAR confidence intervals are wide. Sometimes if the numbers are small, they're going to be huge confidence intervals. That's the formula. And yeah, sensitive to missing data, and it doesn't account for community capacity, the values, and the will. All these kind of things that you do take into account when you're working on your Title V priorities, for example. You need to take into account those things. So the PAR number is just a starting place, and the discussion has to include a lot more stuff. But for you who are doing numbers often, I mean, you want to be able to provide that starting place. And we do have a spreadsheet which I can share with you along with these slides. A spreadsheet to help the calculations get easier. We built in confidence intervals and some sensitivity analyses too into the spreadsheet. Any questions about that? We are in prioritizing based on just numbers. So yeah, other considerations. Our community needs to ask what other data sources should we be doing? We often get sort of trapped into these things are the things we can look at because of our vital records data or other data sources too. So we just look at those and we forget that there's other things, and we kind of need to open it up. And that's another place where community members can help. Open it up to what do you think the causes are? What should we be looking at? Don't limit ourselves to just data sets that are already there. I mean, I think we should use those first because they're already there. It's almost, unethical not to use them, but we should go beyond them too. And we need to look at things like, is the factor modifiable? Does the scientific literature say it can be modified? Can it be modified for populations that are like ours with the same kinds of risk factors as ours? Or did these studies occur in some kind of special population that's different from ours? And this is another place where the community can be involved in this discussion. And then the political will and the resources. Do we already have programs that we can build on? That kind of thing. So back to this community and multiple perspectives, bringing multiple perspectives into data stuff is really important. They can bring things that nobody who's sitting in the office would ever have, experiences that you don't have. Often EPIs don't even live in the community because EPIs tend to move around a lot. So we can bring in also multiple professional sectors to help you interpret things, like people from the education sector, the justice system, social services, housing, people that work with the population that we're serving, they can be very useful too. And you need these people because otherwise it tends to default to healthcare. Healthcare people are already involved and they have a certain perspective and they tend to carry a lot of weight. So you need to push to bring other people's perspectives in. The same way you have to push to bring non-white perspectives in still in the United States. So in Urban County, when they got this infant safe sleep being a big issue, they realized that it was more than just back to sleep, that they'd been giving a sleep on the back message to everybody for a long time, and that wasn't working. They needed to go beyond that. And so they needed to explain about other safe sleep factors like not co-sleeping and not sleeping with blankets. And they also decided to bring in physicians to educate about smoking cessation services for pregnant women. And even though there isn't always a big effect of smoking on SUID, it's such a good thing to do anyway. And here this adds some motivation. So it's kind of a it's kind of just practical from the point of view that it can influence a lot of other outcomes. And they also partnered with a group that was working on maternal mental health issues because that mental health and drug and alcohol use are associated with SUID. So I wanted to introduce you, if you don't already know, who has heard of We All Count, the website We All Count? Anybody heard of that? You're supposed to, oh, there's somebody, Nicole. Anybody else? No, everybody else is, yeah, there are some. That's good. It's a great, it's a website and they have free online community forum that has presentations on every Friday. They have a website that you can just look up these presentations forever. They're stored there and they also have some trainings that you have to pay for. So they make money that way. But Heather Kraus is the start. She is a statistician still and did a lot of evaluation work internationally, but she lives in Canada. And she really got tired of doing evaluation work that was racist, she thought, and really having a wrong perspectives. And her premise is the data are never value neutral. So what we need to do is discover the values, discover the frames, and try to undo the prejudices that are leading us astray. So I'll show you a little bit about what I like about what she does. So this is an example of how to involve the community in the choices about what to measure and really how to think. But the microscope has a person looking into it, the eyepiece, and that's the viewpoint that gets centered. You have an issue here, which might be no high school diploma is an issue. And if the people who are getting studied are the students, the question that you can answer is what % of kids don't graduate? So that's sort of a framing of the research question. But if you look at it a different way, if you change things around a little bit, you can still have the same issue, no high school diploma. But what if someone else looks through the eyepiece? The students, if they look through the eyepiece, the question that they might want to answer might be completely different. Like what % of my classes helped me get a job? Or which school should I go to that will help me get a better education in this city? Which schools have the best programs? So this is a tool you can use to help really in a meaningful way pull in other perspectives and change your own thinking, open up your thinking. Another way is to have community be involved in these little sort of like a DAG chart, a causal diagram. So if we want to figure out why so many unmarried parents are having very low birth weight children, we want to open this up to not just the things that are on the vital records, but to a group in your community, to maybe a focus group sort of situation, and go to what do they think? And they might think a lot of things: chronic stress, unwanted pregnancy, unsupportive schools, access to family planning, drug and alcohol use. So some of the same things might come up, but some different things might come up. So this is sort of a way to just open things up and say, well, if they're interested in chronic stress, how could we study that? What data set can we go to, or can we do our own research if this is really an important issue to the community? Proxy variables is something that everyone knows that we should be careful of. That's something that we all count worries about too. Sometimes a proxy variable is the best you can do, but you need to report it in a way that makes it clear why you're using it, what's it a proxy for, and why you're using it instead of using the actual number. This happens to us a lot when we're relying on data sets. We only measure a few things, and like using maternal education for socioeconomic status. Why is that important? I mean, I think it is. It's a good way to measure socioeconomic status, but why? You should explain why.
How do you explain the concept of proxy to folks that don't have a epi background or public health background? Because like we're going through those things right now, and one of the hardships for us is to communicate that clearly for the general public because we're trying to produce data for the community.
So what variable are you using that is a proxy?
Maternal education, marital status, and health insurance.
Mm-hmm. Well, when this happens to me, sometimes I can bring it to the community. I have my own theory and I can put that out there, but I can also ask them. We found that this was closely associated with with our outcome, very low birth weights, say. Why would this be that so many people who have low socioeconomic stat or have low educational attainment would have low birth weight? I think it might be that because maternal education is closely related to what kind of job she can get how much money she earns, how much status her job has, how much stress her job puts her under. Sometimes jobs where a person has higher education, they're more secure in their job. So they don't have that stress of always worrying about, are they going to do well enough? Do they have to sign in and sign out, and or do people respect her on the job? So maybe it's a stress thing. The other thing about maternal education is that it's a proxy. It is associated with what resources her parents have, because often the parents pay for or help pay for a college education or make it more possible by supporting them through high school. Um, so that is also related to health because it might reflect her diet and other health related factors, her health care growing up or her stress level growing up. I would open it up for discussion with them, not just present, but maybe give some theories. Have you had some experience doing that? Have you?
I
Why
have
is it a concern for you? Have you seen it not work?
it's just because um like the what you mentioned before, like the discriminatory data analysis in South Dakota in particular, those things tend to reflect on Native Americans, which adds to the overall already present stigma. And I want to do things in such a way that I'm going the other way around. I'm not increasing that stigma, but actually elevating the population.
Right, right.
And the way that I present that matters for that. You know what I mean?
Yeah, yeah, I do think it does. Um, I well, I told you the Eileen Doolittle story. I mean, Eileen Doolittle in Portland, Multnomah County, worked hard at getting the data to be used by the people that it was about, by bringing the data source to them and letting them discuss what was good and bad about the source until they were really asking the questions themselves. What questions you need answers for? I think that a close relationship with the community is the best way to do it. That's difficult. I mean, those relationships take time. So there's not a quick answer that I know of. Would other people like to chime in? It's not just it's not just this question here that's on the screen using proxy variables, but it's also um, how do you how do you frame things so that the victim so that you don't um, blame the victim, because that is one of the things that we tend to do as humans. Uh, it's one of our human brain failings, blaming the victim. One of the things that's recommended now a lot is to really do the causal explanation. Don't ever say just, oh, Black people have this and this and this bad problems, but explain the whys that are known. Um, that there's chronic stress, there's intergenerational stress, there's poor diets in early life. Because if you don't explain the real mechanisms that are known, people assume things. I have been to lots of community meetings where I show something like, very low, like, well, in the infant mortality disparity. And if you ask people, why is there an infant mortality disparity between Black and white, just as an example, people will come up with shaken baby syndrome as the first thing that comes to their mind. And you need to head that off with with information, with a story of say, this is a common story that happens. There was no there was no shaken baby syndrome. There was a very preterm labor, and a lot of this lady's family and neighbors had preterm labor too. And preterm labor is caused by stress. Um, I don't know. I'm rambling on. Does that help at all? I see a question from Tanaya.
Well, not really a question, but and
An
I guess it's part
answer.
of our training where we tend to focus on the negative. But when you're talking about involving community and we all try to create these hypotheses or stories to explain certain phenomenon. On the flip side, Washington State has a community, non-white, Hispanic community in Yakima County, which is mostly migrant and farm workers. And the birth outcomes are really good. Prenatal visits, the well child checkups, immunization, everything. Well, I mean, knock on wood. Is really good. And I keep telling folks, I was like, I know we want to focus on and trying to kind of lift or look at some of the problems, but can we also look at communities that by all some of our other findings shouldn't be doing well and is, and trying to kind of explain or investigate what's going on there.
Going right.
Uh,
Yeah.
yeah.
Mhm.
So but that people can make other stories that way too, but I just
Yeah.
trying to
I
flip
think
it a little bit.
the what's going right stories can be really,
Yeah.
yeah.
Yeah. And what can we learn, about is it community health workers? Is there something that we can learn that we could take to a different part of the state or can we learn and trans translate that to an urban area or something like that. So,
Mhm. And I was thinking that data might not be the best vehicle for transferring that knowledge. I mean, maybe that's a time when ambassadors from that community where something's going right could go and tell their stories to more people, or even to legislators.
yeah, well, and like the data people working with program and saying, "Hey, look over here," and then because the program people really do know community folks and is there anyone that we can talk to? And that's how usually I get started.
And that's kind of what PPOR does in a way, because it takes that reference group is a real population where things are going well. And our whole analysis here is comparing our population to the reference group with the assumption that everybody should be able to have things go that well. And why it doesn't is the question that follows this analysis through. But yeah, it isn't clear just from the PPOR numbers results. Thank you. Feel free to make comments like that. Let's see, what time is it? 1:44. We got plenty of time. I will continue, but we can go back if we want to. Pulling in other data sources, use the census data. Now, this is an interesting question because to use census data, you need to have good geocoding on your vital records data. Well, at least to link the census data to the vital records data. That requires good geocoding, and some places have it and some places don't. So what that means is they get an accurate address for the mom at the time she's delivering, at the time she's in the hospital for delivery. Where does she live? What's her address? Some places go ahead and automatically do that geocoding as it's pulled into the vital records system, and they can check for errors actually, and even check back with the mom. Was this a typo on your address? Did we get it right? Where are you actually living? There's some problems with that because there's some traveling that happens in some places especially if they live in a rural area, a reservation. People come in and live with their cousin when they're close to delivery, so they can deliver at a better hospital. That happens quite a bit. So it's not perfect, but it can be very helpful to have good, well geocoded vital records data and then link it to area level, geographic level, neighborhood level factors like this. And even if you can't, you can still talk about the geocoding. The CDC has a process like that gives even county level data can help with making people start to look at social factors and what the causes could be. Hospital discharge data is another source that sometimes works depending on what your topic is. It has to be something that you're hospitalized for, and birth is a good one because people are usually in a hospital to give birth, or a hospital or a birthing center, or emergency department. Those would be included. Insurance claims data is another place to look. That is especially good when there is something purchased or a diagnosis code that you're looking for. Electronic health records pretty much have everything, and that data is getting more and more available to people. Insurance claims data, by the way, within a state, Medicaid covers, somewhere around half of the births nationally. Sometimes the Medicaid claims data is helpful all by itself. Some states have what they call all payer claims data sets that they're trying to put together all the payers. Some states also have all the electronic health records pulled together into a database. I would say use these things with caution. Be careful about, do they really include all? Because sometimes that's just a theory. They need to verify whether they've really got all or not. And these things are difficult to share. There's a lot of privacy issues involved. And so some states are good at it, and some have been doing it for a long time, and others not so much. And the funny thing is that some of these people who manage these data sets don't really have any idea what it means when some of it's not there. Like to them, their whole world is that data set. So you have to be the one that says, "Oh, wait a minute, the whole world is everybody who lives here." I want to make sure everybody who lives here is well represented in that data set. Another great one is PRAMS. It's great for state level stuff, and some local areas oversample PRAMS. Nebraska is an example of a state where a lot of we oversample by race in Nebraska. So the smaller race groups, it's pretty necessary in Nebraska because it's a very majority white state. But since we oversample for non-white race groups, and a lot of the non-white race groups live in Douglas County, Nebraska, PRAMS actually is pretty good for us doing Douglas County, Nebraska risk factors. So you might be able to use PRAMS data if you have a situation like this, or if there's an oversampling that's paid for. And BRFIS, I don't know why that's above, but BRFIS is very good for general risk factors. BRFIS is not good for isolating who's pregnant, who's had a baby or not, but it's good for, women of childbearing age. And how is one population doing compared to others as far as non-communicable diseases, risk factors like that. Any other data sources that would be on your mind that might be available to you to add important information about risk factors or protective factors? Going back to Tanaya's question. Some of you probably work with data sets that could be used for this. Okay, no spot putting on, I won't do that. So learn about them. Learn about the data sources that you have available. Sometimes there's not good overlap between the maternal and child health people and the data making people. So make friends with people over on that other department. Want to talk about the blue box, the other periods of risk, and the blue box is usually the biggest. It's one of the biggest in most cities. So that, if you remember, that is the babies that are born at less than 1,500 grams, and they die either before they're born as a fetal death, or in the neonatal period, or in the post-neonatal period. So they can die at any time during that first year and prenatally. So we still have the same steps in phase 2 for the maternal health and prematurity period. We have to identify the causal pathways or the biological mechanisms why there is excess mortality. And if we tried to use cause of death like we did in the infant health risk period, it wouldn't work very well. And that is because a lot of the causes of death for babies who die in that risk period are, well, a lot of them start with the letter P and they're related to prematurity. Some of them start with a Q and they're related to congenital anomalies. But they are often really not pointing to the real cause. And that is because when Bill tells this story, he tells it as a neonatologist, Bill Sappenfield, who we trade back and forth teaching this, but he says that, these babies die of a cause that could be really happening in along a sort of a cascade of events that can happen. They're born preterm, they get some infection, they die of pneumonia or something like that, or they die of an infection in their intestinal tract. But we don't know which the doctor is going to put in as the cause, and which will show up on the algorithm that the CDC uses to choose the underlying cause of death. But that is because there's a whole bunch of causes. These babies who are born very tiny have a lot of problems. They're really complex cases. So sorting it out by cause of death doesn't really work. So what we're going to do is use patterns instead. And I'll show you what that means. And here's the first one. This is the main thing. So a tale of two cities. We have a city named No NICU City. There's no foreshadowing here in this tale. And then another city called Tiny Baby City. They both have 1,000 births and they both have 10 very low birth weight deaths. And our question as public health people is, how can we prevent these deaths, right? We need to know something else in order to know how to prevent them. We need to know this. We need to know how many were very low birth weight births. So in no NICU city, of those 1,000 births, only 10 were born very low birth weight. So it's very, very small, very low birth weight rate, but all 10 of them died. So what this means is it's a poor survival rate because they have no NICU, right? That's the obvious problem for no NICU city. Very poor survival rates. They need to get a NICU. They need to get better care for those babies that are born too tiny. Now, Tiny Baby City has a different story. They have a much higher rate of very low birth weight births. 100 out of every 1,000, 1/10 of the babies are very low birth weight, which is high. But they do pretty well on the survival rate. Only 10 of those babies die. So what they need to do is completely different from what no NICU city needs to do. What they need to do is prevent babies from being born so tiny. So it's really important to know which kind of city we're in that's the pattern that we need to look for in order to know what to do in our city. So what we need to know is the mortality rate for a very low birth weight baby. And we have a little formula, very simple formula. It looks terrible when you write it this way, but it's called the Kitagawa decomposition formula. And what it decomposes is the difference between the reference group and the study population. So it stratifies the population of births. Then we have, in our regular way of doing it, we have 4 strata in the very low birth weight group. And we have 3 more strata in the higher birth weight group. What the P's are is the proportion of babies that are born at that birth weight. And this means it's an average of the proportion born in that birth weight between the study group and the reference group, the average. And then this is the difference in mortality rates. So it multiplies the average proportion born in that stratum, which is one of the very low birth weight strata, multiplied by the excess mortality rate in that stratum. And then you add that to the same thing reversed. The average of the 2 mortality rates, reference and study group, and the difference between the proportions. And Evelyn Kitagawa was a demographer in University of Chicago, and she figured out this formula, and all it does is divide up the excess mortality overall into 2 components. One component is that no NICU component. The birth weight specific, the proportion of that difference that's due to birth weight specific mortality differences. So the survival rate differences. And the second part of the partition is the proportion that's due to the birth weight distribution. I think that's wrong. The way it's written down there is wrong. It's the birth weight distribution. How many babies are born in the very low birth weight categories? And I'll fix that before I send it to you. So the maternal health and prematurity period really makes a pie chart of the excess mortality in the blue box. That's really what it does for us. And in this city, in this study population, we find that almost all, 93% of the excess mortality is due to birth weight distribution. This, and only a small percentage is due to differences in health care after the babies are born, very low birth weight. Am I making sense? There's one nod. That's very helpful, Nicole. Thank you for nodding. All right, there you go. So this is a very common picture to get for African American populations. we know that this huge difference in mortality rates for between black and white all over America. There's a huge difference in most cities and most rural areas, and it turns out that this is one of the biggest differences. A lot of it is attributed to this dark blue thing, birth weight distribution, too many babies being born too small. And that's getting to be pretty obvious. I mean, if you look at just the low birth weight rates, at much higher low birth weight for African American populations, but it's still in your community, in your hospital, they might be worried about survival and getting more NICU care, getting better NICU care, getting more staff for the NICU. This is not going to help us. We need to work on more upstream stuff. We need to prevent those very low birth weight births. And this gives you some justification for that, for doing non-medical solutions, partly because some of these babies are born at 32 weeks, 30 weeks, 28 weeks. Often they're being born too early for us to solve all their medical problems with prenatal care. So this is why it's called the maternal health and prematurity period, because a lot of the intervention needs to be in changing mom's health even before she's pregnant. So this is a helpful thing for health departments that are trying to work on prevention. This tells them, yep, prevention is what we need in this case. And anybody, any comments on that? Any experiences or contradictions are okay too. We can talk about those. I love good argument. I'll go on. So I mean, it's obvious that the solutions would be different, but this is a list of risk factors that are different. And in that next step, we're going to look at risk factors, right? So we have a list, and this is not a perfectly complete list, but there are a lot of risk factors that you would look at if you have one problem versus if you have the other problem. If you have a very low birth weight distribution birth, you need to look at factors. A lot of these are things that have to do with the mother's health through her life course, through her pre-pregnancy periods and early pregnancy as well. If you have a birth weight specific mortality problem, as the answer that comes up is a big issue, which it does in some places, not so much for Black populations, but for some places there are real big disparities in who gets good treatment after they're born very low birth weight. You want to know if this is happening. And when this happens for health departments, I always tell them, go to your neonatologists, bring them in because you need them on your side if it gets to this point. They know about these systems, the referral systems, what the care actually looks like, why maybe one group doesn't get care as well as other care as another group, and they know the complications that they tend to see, and they're going to be good advocates for whatever the solution is. So if this comes up, bring them in. This is a case where public health needs to work with healthcare and healthcare systems, insurance companies, maybe. Questions, comments? Nah. Okay. And this is really important also to bring in those other data sources. Some of the same data sources that we had before. Tanaya is going to talk.
Yes. Can you go back to the previous slide, please?
You bet.
Yeah, so thinking about referral systems, so that is I'm trying to think of or maybe you can think of a good example. Because I think you're also talking about some gaps in data. I'm trying to, because when we talk about like folks coming in, I know with us, we can see when someone started prenatal care, and it may be delayed But what we don't see is that maybe they try to get prenatal care as soon as possible, but a provider said, come in your second trimester. And so we don't see that. We just see, eventually when they interact and successfully engage with the healthcare system. And so there's just gaps in the data and that we can't see. And so like referral system, I think that they can get some of that just through surveys, how much time did it take you to get in or wait time to get an appointment or how much time did you wait in the office? But doing like a unless you know of something else, but just trying to capture that, which I think is really important because, clients, particularly our clients that are pregnant and have a substance use or behavioral health problem, may get turned away. They're trying to engage in the healthcare system, but get turned away, and then they don't come back until delivery. So, trying to identify, even if that's an issue, is I don't know if you, yeah, know of where we can actually see that.
I
You
think
know,
it is going to be different for each place, but one of the things that they look for in a referral system is to make sure that a mom who has some risk factors is going to deliver in a place that can take care of that baby. So either she needs to get, if she shows up at a hospital that can't take care of a baby and she's in labor at 28 weeks, they need to have a system of transporting her to the right hospital. But ideally they would teach her about her risk so that she would know ahead of time, which is, that doesn't always happen. But to make sure she gets pre-admitted to a hospital that's high risk if they know that she has risk factors.
hmm
That'd be
Yeah, we
one example.
Okay, thank you. Yeah, okay. I guess I was thinking of referral as, broadly, but yeah, we can't see that on the birth certificate, whether someone
Yeah.
was transferred, and then
Well, you can see if they were transferred.
yes, yeah.
Yeah,
Oh
yeah,
yeah,
yeah.
that's what I said. Yeah,
Right.
you can see that, and
But you
then
don't see the whole story.
no,
Yeah,
no.
right.
And we also
Mhm.
can see, we meaning Washington State, do offer doula services to Medicaid clients as long as they're low risk. So we can see, within the claims, like maybe someone started with a doula and then maybe something happened. And so we can see some of that movement from providers, but yeah, it's kind of like, you know, trying to, yeah, at least piece some of that together.
Yeah, you're right, piecing it together. Like, how do you see whether a person had a doula or not? Is that in your vital records? Or
No,
hospital records?
we asked the Department of Health with the birth certificate does has a list of, attendees and but there's no room for the doula is not the
Right.
attendee.
They're not the
Um
attendee. Yeah.
yeah, so we use the claims and look at the provider taxonomies. So that's how we do
Good, good.
that. And
Yeah.
and I don't know if you know that. So in Washington State, we have a linked birth certificate and Medicaid claims and encounter system called First Steps Database. So we, at least for the Medicaid clients, we can, uh, that
Mhm.
story is somewhat
Mhm.
clearer, but the attendee information, there's no crosswalk between that and the claims and encounters. So there's like no like a on the claims there'll be like a national provider ID number, NPI. Like we need a unique identifier. And the birth certificate has a name. So so we used to do like hand matching between those two. And yeah, we're trying to develop something. But the taxonomies help.
This is really good of you to bring this up because I want everybody here to know who hasn't done PPOR before, hasn't run into this, that this is not just a matter of running numbers. You really have to be thinking and pulling information from all sources. And I wouldn't discount, asking people at the hospital, how does this work? Ask those nurses who admit the patients. They know a lot of these stories, and they could probably direct you to ways to get, if you need more quantitative information, sometimes, sometimes the perinatal quality improvement collaboratives are collecting data like this, and you can call on them to help you if this sort of thing has risen to the level of importance that they're working on it. And their hospitals do track things for them. And so you may get some answers from places that beyond vital records, you really do have to think through these things. It's a good thing to bring up. Yes, think of other data sources. Ask people. Transportation, is there a way for the person to get to that hospital that she needs to go to? In our county, it's a big urban county. On one side, it's very urban, and the other side, it's pretty rural. And all the hospitals kind of moved out to the suburbs because, it's because they get more paying clients and a lot of young families out in the suburbs, a lot of healthy people out in the suburbs. But that means that people who live in the urban part have to go far away, and there's no bus service out that way. So how are people going to get to the hospitals where they need to go? This is complicated. So this is that same schematic that I made for the maternal health prematurity period. You find out in the first that you got a blue box problem in your first step, your phase 1 PPOR. And then in phase 2, your second step is to figure out whether it's birth weight distribution or birth weight specific mortality. And the third step is to investigate the risk factors for that cause that you find is most important to your population. I haven't seen very many places that have more than half of birth weight specific mortality problem. And the places that I've seen have been places where there's a lot of low income white people, birth weight specific mortality problems, like Appalachia or cities that have Appalachian populations. Just sort of my rough memories. So this is that same kind of risk factor analysis. How are we doing for time? We're doing fine. This is a whole bunch of risk factors, and I honestly can't remember where this came from. I take them, I de-identify them so I can share them, but so this one is sort of stratified. The list is stratified according to kinds of factors. So system factors, and they mean healthcare system factors, Medicaid, getting WIC, living in a neighborhood that's a dangerous place or whatever, having a hospital system, which hospital system they belong to, and whether the attendant is an MD or somebody else, a registered nurse or a midwife would be the other choices. And again, all the way calculating the prevalence of the risk factor. This doesn't give the gives the prevalence of the poor outcome. It doesn't give the prevalence of the risk factor in the reference population. So we can't compare that column. But it does give the risk ratio, which is severity, and the PAR. And what rises to the top on PAR? Having twins or more. There's usually not a whole lot you can do about that unless there's an ART program that's gone rogue and they're not managing the pregnancy well. Another one is gain too much weight. So this is one of those non-infectious disease, one of our modern diseases. BMI is high and gain too much weight during pregnancy. And then the mother has less than an associate's degree, so low socioeconomic status, low educational attainment. And then the father has less than an associate's degree. We haven't talked about fathers in here very much in these risk factors. Father data is a lot less populated. I mean, the data quality is not going to be as good in most places. It's a little bit better now that we have the either father or paternal acknowledgement.
Hey, can I see your?
Is that a deliberate question or just a talking over? Andrew, I think it was accidental. But anyway, you have to be careful if you're using factors that have a lot of missing data. And I don't know whether this group was being careful or not. But that the fact that they had both the mother and the father really being probably low socioeconomic status was one of the biggest factors here in producing a very low birth weight baby is important. So that tells this community, well, we can talk about some medical factors, but the ones that are really big are going to be healthy weight for the mom, healthy weight gain, and socioeconomic status. So this may be more of, well, not really addressing the causes, but maybe looking more closely at that population of people with low socioeconomic status. And by the way, that's not the only way to look at it. If I saw this problem and I was going to go ahead, I might want to look at other ways to define low socioeconomic status, like perhaps median income of the neighborhood where the mom lives, since a lot of our cities are very segregated in that way. Go ahead, Tanaya.
So I see it says birth didn't occur in a hospital. Is that the intended place of birth was not in a hospital or unintended? Because,
Well,
you
we don't have a
know,
way to know. I don't think we can know.
oh, wait, I guess our birth certificate, again, Washington State does have intention, so we can see whether or not we haven't done any data quality, but we do look at that. Like when we're looking at community births, we want to know if they intended to give birth at home or at a community birthing place, because we do see unintended, obviously at home or like on the way to the hospital, and we usually have to exclude them from certain things. So okay, thank you.
The prevalence is pretty low,
Yes,
1.2%. And
yeah,
since
it's
I
very
don't remember
tiny.
where this is, I don't know how many community hospitals they have or that sort of thing. So I can't tell you much about that. And I don't know whether they could have either. Um, but that's interesting that you know whether it was
Yeah.
intended or not intended. Um, there's a lot of stuff like that that's not the same for all states. So it's good to know what your state has on it. That's good.
Yeah, they sometimes the Department of Health changes a few things because yeah, like you're saying, there are, I think, just some state specific either fields or codes they've been
Yep.
using for a long time, and they're starting to align more, I think, with the National Center for Health Statistics. And so I'll give you an example. We used to have like state specific county codes, and they took those out and started using the like the census county codes. And so that kind of gave us some heartburn for a while. But okay, well that's interesting that intention is not a um like
It's not on the
more,
standard.
yeah, standard birth certificate.
Yeah. Important. Another thing to notice in this chart is that the ones that are high prevalence are not necessarily the ones with the high PAR. You know, the the high risk ratio. So it's both risk ratio and prevalence. That's just the PAR thing. Oh, yeah. What systems? So you might want to ask here, what systems affect obesity? Can you look at census data? Can you look at things like neighborhood walkability or things like that? And a lot of people are interested in food deserts. Are there grocery stores? Can they get healthy food? And a lot of other people are looking at medical practices like PRAMS talks about, ask some PRAMS versions, ask questions about what their doctor talked to them about. Was there some health counseling available for the pregnant women? I wanted to just do this. This is something that I did for research purposes. I kind of wanted to know how things were distributed. So I did the excess mortality divided into 6 parts, the 4 periods of risk, and then the infant health period divided into 2, and the maternal health and prematurity period divided into 2. So for each city, then you can make a pie chart with 6 slices, which I understand goes against the rules for displaying pie charts, that our brains can't handle 6 slices, but I did it anyway. And I wanted to see whether there was differences across the country, whether all the cities were the same. Because sometimes when we do this a lot, you kind of think, wow, I've seen that before. It's all the same. But it isn't. And so I just did like the biggest 100 cities in the United States and did the 6 components. And the component that varies the most is the maternal health prematurity period, just the component that's the birth weight distribution. That's this top blue line here. There's a lot of variation in how important birth weight distribution is for the cities with the lowest infant mortality overall. The birth weight distribution varies from about 0 all the way to 3.5 as excess mortality rate. This is all translated into mortality rate, so it's deaths per 1,000. The next highest one, which is also the next biggest spread, is the pink box, which is the fetal deaths. And that has a lot of spread. There's some counties where it's a very important part of their excess mortality, and other counties where it's really not contributing at all. The one that contributes the least is that birth weight specific mortality, but there's a few places where it is up to about a half of death per 1,000 live births. So that's contributing quite a bit to the counties, or these are all counties where there's low infant mortality rates. This can be an important chunk. So NICUs can still be an issue in some places. The safe sleep is the solid green bar, the sleep-related infant death, and there is quite a bit of variation there. Anyway, so I just wanted to prove to myself that there was a reason for doing this. And they don't very quickly over time. If you have a problem in the pink box, which we just saw, a lot of places do. Pink box is a big deal for a lot of cities. That means you have to look at stillbirth data. And the fetal death records have a lot more missing data. And the worst part is they have a lot of missing data in the maternal demographics, things that we would use for PPOR, like race. And the biggest one is maternal education. There's a lot of places that have more than half of their fetal death records don't have maternal education filled in on the fetal death record. Neelish or Neil?
Yep.
ahead.
What was the y-axis on the previous slide?
It's mortality rate.
Okay, thank you.
And that is published. I think that very chart is in that article that I sent to you guys, or that Ashley sent. You can look more detailed if you want. The other thing about fetal death records is the causes of death are not very specific. A lot of fetal deaths don't get autopsies for for one thing. And causes of death, even if they do get an autopsy, a lot of times they don't know. They don't end up knowing what the cause was. Fetal deaths are still a bit of a mystery. There's more research in it. There's more research going on fetal deaths, but as it is now, yeah, and there's no params that's equivalent for fetal death. So there's no interviewing of the moms for a fetal death afterwards. So you can't explore those kind of factors that could be found in a live birth. A lot of times we end up using birth certificate data to look at risk factors even for fetal deaths, which is not ideal. The fact that there's a whole bunch of missing maternal education is sort of a plug for looking at other factors to use to make reference groups, other factors to use as a proxy for socioeconomic status. And here I think one of them could be qualifying for Medicaid, since pretty much everybody except certain immigrants can usually get qualified for Medicaid if they're poor. So that could be a good proxy for being poor. And another possibility that I have looked at a little bit is using the median income for the neighborhood where the mom lives in. And that, as I said before, depends on geocoding and how well the address is entered in. But it's difficult to do stillbirth analysis. But there are known risk factors for stillbirth. Maternal age, weight and weight gain, hypertension and diabetes. And the caution here is because that is underreported. It's known to be underreported on birth certificates. So here you might want to look at other data sources. You might want to look at hospital records. If you have a big stillbirth problem, you have a data challenge right from the start. But it doesn't mean you shouldn't look at it, because there's more stillbirths than there are infant deaths. And it is an important indicator of health problems and sort of community health, just the way infant mortality is. It's not the case that all stillbirths are what meant to be. Some are preventable, and we're not very good at it yet. So it's kind of cutting edge. So, but there are disparities in risk factors that can help guide you. Again, you do the same thing. You compare the reference group to the priority study population. And that is guiding you toward, well, what should we be working on to improve stillbirths? And the newborn care risk period is the least common to find disparities. When you do, it tends to be populations that don't have easy access to high quality hospitals. Like they don't go to level 3 hospitals. But because the NICUs, the people who do go to level 3 hospitals get pretty good care all the way across the board. So this tends to be maybe an urban-rural issue. And we may already know about these issues. I mean, we already know that this care is a problem. And so what you might do if you see a problem in this is use it to advocate for NICU, better distribution of NICUs or better access to NICU care for people in rural areas that have risk factors. That's all I've got. Happy to go to more questions or give you a break. Could open up the Excel sheet if anybody's interested in geeking out. But I bet you're probably just brain tired by now. Stop. Any questions? Had enough? You've all been very good. I hope it's interesting. I should look at the chat.
Well, thank you for mentioning the Katagawa, because that's when Ashley was mentioning like, any suggestions for, like a refresher. I definitely think I need a refresher for for that.
Well, it's not that hard. It really isn't. Um, and it's easy to do with the template. And it's kind of fun to make your own template if you really want to understand it. That's the way to do it. But um, but if you don't want to go into that much depth, you can just use the template. But it's not really as hard as it looks. That formula has just looks intimidating, but that all you're doing is adding up differences, multiplying them together and adding them up. Pretty simple math. We just like to make formulas like that look scary. Utah and Ohio have a PRAMS version for stillbirths called SOARS. I did not know that. That's good to know. How long has that been going on, I wonder? If there's data out there for it yet.
They Utah started it, and I believe they have a couple years of data. And then Ohio, it's not with the state, it's like a college of, I can't remember what it is. It's like a conglomerate of all that stuff. Yes, yes, someone's speaking about it. And then they did put out a CDC is funding for a couple more jurisdictions to do SOARs. Philly's one of a. I'm in Philly. We're doing it, and then I think Georgia is the other one.
One of the things that we always say, and it really works. I mean, when you start to use this data and you publish, you go out in the community and to the stakeholders and talk about the data, and it makes the data improve. It makes people start asking questions, and not just to add more surveillance systems, but to improve the quality in the surveillance systems that we do have, like the presenting to residents to teach them about the value of infant mortality and the value of the work they do. They'll say things like, "Oh, I didn't know you actually used that data that I filled out," like it just but it's hard to keep hammering and hammering over the years and catch all the residents. But this is good news. I'll have to look up that Utah and Ohio stuff. Thank you all for your good questions. And I will give to Ashley the spreadsheet that is calculation template. It's just for the kind of repetitive calculations that you have to do, so you can just plug in numbers and not have to make your own. It's a time saver, but it does not save thinking. It does not replace thinking. I even put that in the spreadsheet. You still have to think. Okay, anything else? Closing messages? But we could do a Kitagawa session if you guys want to. I'm sure Ashley could organize that.
I'm the squeaky wheel. I would certainly open up to anyone.
This was great. Thank you. Ashley, are we definitely having a third session or?
Yes, I'll be gauging interest on third session and what that plan, like what topics it would be
Uh-huh.
open for you all to either select something that would be complementary to any of the sessions we've had throughout this training schedule, or if in addition to, like if a topic that we hadn't included in the training session or schedule. So
I rescind my suggestion in favor of Nicole's on geospatial analysis.
that's an option.
Yes, at the wonderful City Match conference in Seattle this year, we got to, I went to several presentations and there was someone from the March of Dimes, and that was really awesome and thought-provoking about uh, we do get alarmed when hospitals close, but there was someone, oh, I'm so sorry, I'm forgetting. But maybe there are advantages to certain hospitals closing. So, um, and folks going to maybe a higher quality hospital or increasing a hospital's like how many patients and experience. I'm really wording it wrong, but it was really good. And I don't know if that's where you're going, Nicole.
Wanda Barfield is really a fan of planning those hospitals, those level 3 and level 4 hospitals. Not just having a bunch of them wherever they crop up, but really being strategic about them.
Mm. Yeah,
Um,
tonight I've been dabbling in the census APIs this year, which is why I'm just like very interested in the geospatial analyses.
yeah, I was going to aggregate to the geospatial analysis. Like, if we could parallel that with census data. During the City Match conference, I actually went to the American Community Survey presentation, and I realized I honestly, like, I have been using the census data for reference for a bunch of my studies, and I realized I had no idea what I was doing, and I was doing a bunch of things wrong because I don't really fully understand how the census data work. And I know that the folks at the American Census Data, they're willing to come and provide us trainings on those things and the differences between 5-year estimates and the last year's estimates and what that implies to our presentation. So, and I think that, like, parallel putting that together with the geospatial analysis would be super helpful, because, like, a lot of the data that we use for geospatial comes from the census anyway. Yeah.
IPMS might be a good source of training for that. It's at the University of Minnesota. They get paid to put out census data in usable form, and they have some good trainers there. I guess that's for Ashley or the faculty to figure out.
That the University of Minnesota School of Rural Public Health?
It's a center.
Oh,
I
it's a
don't.
center.
It's not in the School of Public Health. It's a separate center, I think. IPUMS. Don't ask me what it stands for, but it's easy to find. Oh, ArcGIS.
Mm. I'll also share when I am asking about feedback on session topics, I'll include a couple of the previously recorded post-training webinar links as well. Michael Kramer has done some spatial analysis. It may have been more of a beginner level, but we could always see if he's interested in doing more. But I'll link a couple of the archive recordings too from the last 2 years for post-training webinars.
Geospatial in R and SAS can do geospatial too. So you don't necessarily need expensive programs that you don't have already. Yeah, look at that.
All right, thanks for these ideas. I'll start doing a little bit of list curation. You'll get slides and some additional materials from Carol and I and an evaluation. So please fill that out. And then you'll be hearing from me. I will be respectful of holidays, so I'll try to get one in before with enough time. I won't be scheduling anything too late into December, but we'll try and get another one on before the end of the year for you all. So keep an eye out on for that. Otherwise, thank you.
Nice
Thank you
seeing
so
everyone
much.
again.
Thank
Thanks, Ashley.
you.
Thanks, Dr. Gilbert.
Thank you.